Thank you, Vamsi. Good evening, everybody. Thank you, organizers as well. Yeah. Just wanted to let you give me permission to share, and I'm now sharing my screen. Yeah, right. Am I heard as well? And my screens are visible?
Yes, sir. We can hear you and screen
Yes,
is
sir.
visible.
It's visible.
Great. Yeah. Thank you. As Vamsi said, this is a very controversial topic, and in the interest of time, I will try to fast forward this presentation as well with evidences. The traditional thinking was stage 4 breast cancer, or always has been a heterogeneous disease, even now. The traditional thinking was cure possibly is not possible. That was our earlier thinking. But now I think we know that a subset of patients of metastatic breast cancer can be brought into the realm of cure. But by and large, cure seems unlikely in a stage 4 breast cancer. Having said that, the median survivals of patients have drastically improved ever since the time of a couple of decades. Now, as much as median survivals may be in good responders, maybe as much as 3 years. Of course, the range is between a few months to many years. Of course, the reason for this hope is effective systemic therapies, endocrine and biological. And I'm sure that during the course of the webinar that happens in the next hour and a half, we'll be discussing more about this. This has been there specifically in the HR positive and and also the HER2 positive space. Also in the triple negative space, we do have some improvements. But by and large, if you see, the factors affecting the outcomes are a byproduct of the tumor and the treatment related factors, important considerations being the age, performance status, comorbidities, extent and biology of the tumors. And more importantly, the presence and availability of the effective systemic therapies. So by and large, if you see a stage 4 breast cancer, the evidence-based guidelines broadly says that systemic therapy is a mainstay of therapy. The issue for that we are trying to discuss today is of local management. Local management maybe of the primary breast cancer, and that's what I'll be focusing on. There's also a lot of interesting data coming up in the oligometastatic sphere of metastasis-specific local treatment. I'll just briefly dwell on it for the interest of time and conclude my talk. When it comes to local treatment, it could be either a conservation or it could be a mastectomy. When it comes to metastasis-specific local treatment, it could be a metastatectomy, it could be radiation, it could be RFA, cryo, or any of the image-guided percutaneous procedures. Now is the more important question that we're trying to address: to operate the primary or not in a setting of a metastatic breast cancer. Of course, the answer I would say is yes and a no, and I would sort of qualify my statement in the following slides. Definitely, surgery is indicated for the primary in a metastatic breast cancer if the primary is symptomatic. Of course, this is an important consideration. If there is pain, bleeding, ulceration, infection, or any other aspect associated with poor wound healing, the act of surgery is justified. And this is not just in this solid tumor, but possibly in many other solid tumors as well. But the issue is whether in the presence of an asymptomatic primary tumor, whether you want to remove it in some form, either as a conservation or the mastectomy. I must say that it's not yet completely considered standard of care, considering that there is not much evidence to say that it really improves the overall survival, and coming to those evidences in some form in some time. But I must say that there could be deviations in this approach, and largely it must be on a case-by-case basis in a multidisciplinary setting. For example, I give you a specific case scenario of one of our patients we had managed, a 47-year-old lady, post-hysterectomy, carcinoma right breast. She was T4B N3CM1, bilateral supraclavicular, and contralateral axillary node was positive. Of course, at that time, we felt that the intention of treatment was palliative. We gave her 6 cycles of Taxol trastuzumab, a PET CT done for assessment, showed a vague residue in the breast and a complete metabolic response otherwise. So we were in a dilemma whether to add loco-regional treatment to the primary, or we should further add metastasis-directed treatment as well. So to cut the story short, we decided in the interest of the biology of the disease, in the interest of the presentation, that we would continue systemic therapy only for this patient. So we continued this patient on single-agent trastuzumab. After 3 months, a PET showed progression only at the breast tumor site. Rest continued to be a metabolic CR. In view of local progression, Again, in this patient, surgery for the local site was justified. Of course, this is not purely in the realm of asymptomatic patient, but because there was a local progression, there was symptom associated with it, we were justified in going ahead with a palliative mastectomy. Surgery is also justified, as I said, in this case, when the dramatic response to the systemic treatment has been there, but subsequently the primary has been progressing, as in this case. Or it could also be justified when the primary breast mass is amenable for resection, it's possibly close to ulcerating. So in this case also, in this scenario also, maybe surgery might be justified. What are the evidences? Of course, you have a lot of retrospective evidence. It's very difficult for me to collate at least 17 to 20 trials of or studies, retrospective studies are set. And by and large, the vast majority of the retrospective evidence actually support local treatment in stage 4 breast cancer. But I must say that the quality of the data has been retrospective. There has been instances of selection bias, and most of these studies have concluded that they required randomized controlled evidences. We have 4 randomized controlled evidences. In this order, I would go the trial from Dr. Badwe et al., the TMH trial, I would name it, the Austrian trial, the ECOG E2108, and the Turkish trial. Very quickly, I would sort of run into each of these trials. The TMH study, 350 patients, resectable hormone positive breast cancers after anthracycline based therapy. If there was a CR or a PR, they were randomly assigned to surgery versus local regional treatment, published in the Lancet Oncology about 7 years back. Median follow-up 23 years, no difference in the overall survival, although local regional treatment was associated with improved local regional PFS. But again, there were slightly questions asked about the availability of systemic therapy. For example, the trial mandated use of appropriate endocrine therapy and HER2-directed therapy, but the criticism was that the majority of the patients did not receive. But that's how the real-world data is. So we had this wonderful trial from India that said that there was no statistical significance in the overall survival when surgery was added in the setting of a metastatic breast cancer. So this observation was also seen in the Austrian trial, 90 patients, stage 4 breast cancer. Of course, this trial was closed prematurely because of poor accrual. Median follow-up of around 37 months, no difference in the overall survival. Surgery also did not confer benefit for the local regional metastasis also, or time to local regional metastasis, or the quality of life as well. Very hot off the press, the ECOG Actrin 2108 trial, 256 patients, published earlier in this year, presented last year, but published earlier this year in the JCO. 4 to 8 months of therapy in stage 4 breast cancers de novo, randomly assigned again to local treatment, no local treatment. A median overall survival of 53 months, no difference at 3 years between both the groups. So there was no difference in the overall survival rates in this trial as well. Of course, there was a 3-year local regional progression was higher in the patients receiving systemic therapy only. The Turkish trial is the outlier trial. In fact, it was one of the first trials, but I was presenting it last because there were 3 trials that were negative. The Turkish trial was the only trial that seemed to be positive. 274 patients, de novo metastatic breast cancer. Unlike the couple of the other important trials in this, the patients were actually offered upfront surgery in the presence of systemic disease, either a mastectomy or a conservation, followed by a systemic therapy versus systemic therapy alone. Although there was no difference in the 3-year OS, the 5-year OS actually favored the surgical arm, 42% versus otherwise. But however, there were a lot of criticisms of the trials that the arms were not balanced in both the groups. For example, patients randomized to local regional therapy had lower rates of triple negative, higher rates of hormone positive. We know that possibly the better prognostic group was in the group that actually received the local regional therapy, and also solitary bone metastasis. We know that most of these patients are now considered as oligometastatic and are actually not considered in the spectrum of polymetastatic diseases. So again, the post hoc analysis of the Turkish trial, we found, or at least the authors found, that hormone receptor positive HER2 negative disease, age less than 55 years, or a solitary bone metastasis. And these were the patients that actually benefited from the upfront surgery group. But as I said, that this is a post hoc analysis, and of course this trial had various other criticisms as well. There is a future trial of JCOG 1017, a similar trial to the ECOG 2108 trial, and we are awaiting the results. Having said that, there is a spectrum of disease called the oligometastatic that's more controversial. I don't really want to throw more light on this in the interest of time. Most of us are aware about this concept, not just in breast cancers, but also in many other cancers like lung, prostate, colorectal, etc. And it is known to be some sort of an intermediate state. Of course, we need to understand many terminologies to understand oligometastasis. It could be de novo, oligorecurrence, induced oligometastatic, or oligoprogression. Of course, you do have level 1 evidence in oligometastatic disease, the Saber-Comet phase 2 randomized controlled trial, which actually randomized patients with 1 to 5 metastatic patients, 99 patients from 10 centers, 18 of them were breast cancer primaries with a median follow-up of 51 months. It found that the 5-year overall survival was best in the arm that was offered treatment both for the primary as well as for the metastasis as well. But again, there were a lot of other criticisms of the trial, considering the fact that it was 99 patients over 10 centers. Breast cancer patients were slightly more, and a lot of prostate was also more. So it had a number of patients with sort of, the biology which was more favorable, and it was a mixture of many cancers rather than one cancer as well. So there are a lot of ongoing future randomized controlled trials that are trying to address this. So I must say, to conclude, I'll just give you a glimpse of whatever evidences are there, retrospective evidences that are largely favoring a local regional treatment for the primary. However, the randomized controlled trials, they were mixed. 4 randomized controlled trials, 3 of them against surgery, 1 of them the Turkish trial for surgery. Of course, each of these trials have their pluses or minuses. I must definitely say that local regional treatment for the primary and possibly metastasis-specific local treatment is in the oligometastatic disease may palliate existing symptoms. That is, if the patient is symptomatic for the primary or symptomatic to the oligometastatic site, you may be justified in offering local treatment in the form of surgery or otherwise to some of these patients, although the impact on overall survival is not clear. But by and large, if the patient is asymptomatic for the primary or the local regional site, the primary goal should be systemic therapy and local treatment should be kept at reserve. However, there could be certain exceptions that can be made in rare circumstances, as in the case scenario that I described, and each of this can be taken on a case-by-case basis in a multidisciplinary form. Thank you for the opportunity and looking forward for the rest of the seminar.
So thank you so much, Dr. Arvind. This was, as usual, excellent lecture. And really, you have highlighted all the various trials. And, we do keep having this discussion in every tumor board. I think this is the case where we have the maximum discussion. What do you do in the oligometastatic? It is sometimes our hope and, wish that all oligometastatic would be cured and let's go aggressive. It would be nice if the data comes to support this, though right now it is not there. So again, thank you so much, sir. I think if anyone has any questions, you can just put it in the chat box as well. We could address them at the end or during the panel discussion. So the next